Boy. Now, we all know that we can be affected badly by extremes of temperature. In cold, we shiver.
And when we're hot, we sweat.
Even during its warmest months, the North Sea never rises above a temperature of 11 degrees. And if you bear in mind that the average human body core temperature is 37, then it's no wonder it feels so damn cold. But this isn't funny. If you're immersed in that for any length of time, you're in real trouble. Your body core temperature will start to decrease rapidly, and that could lead to a potentially life-threatening condition called hypothermia.
On entering cold water, the human body reacts to cold shock by increasing both the heart and breathing rate. A gasping reflex can also be induced, which might result in the inhalation of seawater into the air passages. This could result in a near-drowning incident, which is addressed by application of rescue breathing and CPR techniques as appropriate. Many factors influence both the body's initial response to immersion in cold water and the onset of hypothermia. These factors can be summarized as follows: water temperature, awareness of the effects of cold water immersion, amount and type of clothing worn, physical condition, age, injuries, mental state. Any subsequent treatment following immersion must therefore result in arresting any further lowering of the body temperature by removal from the water, replacement of wet clothing, and raising the body temperature to that of 37 degrees Celsius. Initial immersion results in cold water shock with a rapid increase both in heart rate and breathing rates. Some minutes after immersion, the rates will slow down, but the body's response to immersion in cold water is to increase muscular activity by shivering. Peripheral muscle cooling and dull brain activity during the early stages of hypothermia can lead to an eventual loss of consciousness. True hypothermia is when the core temperature falls to 35 degrees Celsius, and depending on the susceptibility of the casualty, many of those rescued are not clinically hypothermic, but just demonstrating the effects of cold water immersion. For example, peripheral muscle cooling, muscular stiffness, and lack of coordination. Research suggests that victims of cold water immersion can be actively re-warmed by immersion in water at a temperature of 40 degrees Celsius, providing that their core temperature has not fallen below 34 degrees Celsius and they are fully conscious. On response vessels, showers are the means provided for active re-warming, and therefore all casualties must be adequately supervised whilst there. Casualties placed in showers should be seated with their legs elevated to reduce the risk of potential collapse. Hypothermic casualties who have reduced levels of response are best re-warmed passively by gently removing wet clothing, padding them dry and placing them in a sleeping bag or wrapped inside blankets, taking care to insulate them between their arms and torso. Severely hypothermic individuals may have an extremely low pulse and breathing rate, which is very hard to detect. Always re-warm such cases before classifying them as non-survivors. Any rough handling could cause the heart to stop, so be gentle in your approach to dealing with these casualties, for example if you have to place them in the recovery position.
When a casualty is recovered from the water, they're vulnerable to a condition called post-rescue collapse. It's caused by a loss of hydrostatic pressure in the extremities. Now, you can limit the risk of that by recovering the casualty in a horizontal position using a rescue cradle. But if the use of the cradle in any way compromises protection of the casualty's airways, then forget the cradle, just haul them on board as quick as you can, then get them horizontal.
Secondary drowning can occur in cases where immersion victims have made an initial recovery. Although a rare condition, it can present itself sometime after immersion because of the body's reaction to aspirated fluid. This causes inflammation and swelling of the deep lung tissues, which in turn results in respiratory distress. Signs and symptoms can include coughing fits where blood-stained sputum may be produced, breathlessness, anxiety, and shock. This condition has now been redefined as near drowning, as the term drowning relates to those who haven't survived the incident. Survivors who display signs or symptoms need careful observation and 100% oxygen therapy, as the condition can be life-threatening if left untreated. Cases have been known to appear some hours or even days after an incident, and all near-drowning cases should be dispatched to a hospital for a thorough examination when the opportunity allows.
Good breaths, go on. Right, Tiny, just got to take your temperature here. Stick us under your arm, okay?
Following treatment, remember to record relevant details on the documentation provided, and regularly monitor each casualty for signs of improvement or deterioration. Initial and subsequent temperatures taken from the armpit are recorded appropriately on the cruciform card at regular intervals, along with a record of other vital signs and actions taken to deal with the condition or injury. For example, cooling, pain relief, passive or active rewarming, or oxygen therapy.
What have you been doing with yourself?
When assessing a burn, it's important to consider the cause, depth, extent, and site of the burn. Causes such as electricity or chemicals can be problematic, as electrical burns can penetrate to deep tissue and, although superficial on the outside, can result in scar tissue. Chemical burns will continue to burn if the chemical has not been diluted sufficiently as part of the overall treatment regime. There are 3 principal skin layers and accordingly 3 classifications of burn: superficial, partial thickness or full thickness, which relate directly to the depth of burn encountered. A superficial burn results in reddening of the epidermis or top layer of the skin. A good example of this would be a scald caused by wet or dry heat. These types of burn, although painful because of irritation to the nerve endings, generally heal well with no scarring provided prompt action is taken. Partial thickness burns result in blistering of the top layer due to the release of fluid from the underlying layers. Blisters may be intact or burst at the time of receiving the burn, but the initial treatment is exactly the same as for a superficial burn. Great care must be taken to reduce fluid loss and prevent infection to the burn area. Full thickness burns, as the term implies, may involve damage to the full thickness of the skin, including connective tissue, bone, muscle, and subcutaneous fat. As you can imagine, these burns are extremely serious and will require skin grafts at a later date to restore function or partial function. The extent of the burn in terms of body surface area affected can be calculated in adults using the well-known rule of nines, or the simpler 1% rule, whereby the area of the patient's palm is equal to 1% of their body surface area. Some burn sites are potentially more serious than others. Those involving the face and neck area, for example, are potentially more threatening because of the possibility of burns to the airway resulting in respiratory problems. A superficial burn, such as a scald, can quickly be addressed by holding the affected part under running cool water for at least 10 minutes, or 20 minutes if chemicals are involved. This reduces the heat and therefore reduces further damage to the skin tissue relatively quickly. The affected part can then be covered by a non-fluffy, non-sticky dressing, such as cling film or polythene. Cling film and polythene make ideal dressings, as they cover large areas of the body quickly and allow you to continue cooling, if necessary, whilst keeping the area visible. In covering the exposed skin surface, you also prevent infection gaining entry to the area that has been damaged. Take care not to apply cling film too tightly, as swelling is likely to occur, and the casualty's circulation might be restricted as a result.
Not stinking off as much now, eh?
No, it's okay.
Partial or full thickness burns are also treated using the same cooling methods. But when these burns involve large areas of the body, there can be a fine line between adequate cooling and making the patient uncomfortable due to excessive cold.
How does that feel then? You alright? You're cooling down a bit.
These burns should also be covered with a suitable non-adherent sterile covering. A major complication of extensive burns is shock, which should be treated as previously discussed. Swelling at the affected sites can occur and should always be monitored.
That's right.
Rings and jewellery should always be removed.
Right, that's it now, Mike. That's all done. You keep breathing on that. Is the engine not working?
In order to minimise infection when dealing with severe injuries, the environment should be kept as clinically clean as the situation allows. Pain is a major feature of all burns, and much of this will be relieved through cooling. However, no patient should be left in pain, and the administration of Entonox should be considered early, provided the casualty has no other injuries or circumstances that exclude its use.